appropriate for you to get screened for colorectal cancer.
Oh.
You are 65 years old and you have the additional risk factors of a high BMI, heavy alcohol and red meat consumption, and you smoke. You are also at high risk because your father died at 57 from colorectal cancer.
Poor Daddy.
Do you have inflammatory bowel disease, Crohn's disease, ulcerative colitis, or familial adenomatous polyposis?
You know, honey, I don't know what any of those are, so I don't think I have them.
That's good, because we would want to do a surveillance program. I'm going to get Dr. Derriere right now, so just come in this way.
Okay.
Good morning, Miss Fanny Follett.
Good morning.
My CNL, Miss Rump, just handed me your H&P, and after reviewing it, she suggested that you should get a colorectal cancer screening.
Oh, no.
The USPSTF gives the screening a grade A recommendation for both women and men in your age group. There are 3 different methods recommended by the USPSTF to screen for colorectal cancer. There is fecal occult blood testing, sigmoidoscopy, and colonoscopy. The colonoscopy examination has the greatest sensitivity and specificity and can be used for biopsy and removal of polyps. Prior to the colonoscopy, patients need to vacate their bowels. Patients will receive light sedation and lie on their side while the doctor examines their colon with a camera. This should be done every 10 years. During a sigmoidoscopy, the doctor uses a camera to examine the rectum and lower third of the colon. Patients' bowels should also be vacated for a sigmoidoscopy, and this should be done every 5 years. For the fecal occult blood test, the patient collects 3 stool samples and places them on a special card which is shipped to a laboratory and tested for the presence of blood, since 2/3 of colon cancers and some polyps tend to bleed. Certain medications and foods should be avoided for 3 days prior to this procedure. Fecal occult blood testing should be done annually. Colonoscopies are required for all abnormal findings from all other screening methods.
Doctor, they put the camera where? So why do I need to get screened anyways?
Well, looking at this website that I found, even though mortality rates are decreasing due to the screening, colorectal cancer is still the 3rd leading cause of cancer and the 2nd leading cause of cancer-related death in the United States.
Really?
Early colorectal cancer does not have any symptoms, therefore screening is absolutely vital to detect early stages. According to the USPSTF colorectal cancer screening, this cancer screening could save 18,800 lives per year. The Cochrane report shows that the hemoccult test reduces mortality from colorectal cancer by about 16%, and the sigmoidoscopy reduces mortality from colorectal cancer by a whole 28%. What are your barriers about getting this procedure done?
Well, what if they find something like a polyp? The procedure is going to take several hours, and I have to be on the toilet for hours before the procedure to clear my bowels. It's very unpleasant to have to take all of those laxatives and be on a liquid diet. And to be honest with you, I really don't like the idea of Dr. Derriere being down there. They could perforate my bowels with a colonoscopy or sigmoidoscopy, and it's going to get very expensive.
You're right. There are more serious complications in those select patients undergoing a screening via the colonoscopy, including cardiopulmonary deterioration, bowel perforation, hemorrhage, infection, and post-polypectomy syndrome. Additional risks can include an adverse reaction to the sedative and bleeding from the site where a tissue sample was taken or where the polyp was removed. However, these are very, very rare. Overall risk of death from colonoscopies was reported at 0.03% in over 370,000 colonoscopies. Mom, come on. Don't be 40% that don't adhere to the recommended guideline.
Well, colonoscopies sound pretty scary. I think I want to go with the fecal occult blood test or the sigmoidoscopy.
Well, there are some controversies over the different tests. Fecal occult blood test in the office misses approximately 95% of cases, giving false reassurance. And the sigmoidoscopy can't detect right colon lesions. I guess some people are pretty upset about how USPSTF is giving a colorectal screening in adults aged 75 to 85 a grade C recommendation, especially since 43% of cases are diagnosed at the age of 75 or older. The American Cancer Society does not recommend any age limit to colorectal screening.
You know, I just don't know.
Miss Pop totally doesn't want to get screened. What are you going to do?
That's a really great question, Amy. Pop quiz time. What is the health belief model?
Well, the health belief model originated in the 1950s.
Whoa, Amy. Let's just apply it to Miss Paula.
Well, there's a lack of perceived susceptibility since adults tend to underestimate their personal risk. People with first-degree relatives with colorectal cancer have a 2 to 3-fold increased risk. Men have modestly higher incidence than women, and the greatest incidence of colorectal cancer occurs in certain minority populations, such as African Americans and Alaskan Natives. Incidence rates are lower for Asian and Hispanic Americans relative to whites. 90% of all colorectal cancer is found in people over the age of 50.
Wow, I'm so impressed. You must be an A+ student with great teachers.
Oh, but there's more. Many people do not perceive the threat of colon cancer. We could explain to Ms. Pop that colorectal cancer accounts for 11% of all deaths in the United States and affects 1 in every 20 people. According to the health belief model, it is important to consider the perceived barriers to getting screened. It has been found that screening differs among ethnicities. Non-Hispanic whites were significantly more likely to be up to date with screening guidelines, followed by non-Hispanic blacks, Hispanics, and Asians. Older adults are also more likely to get screened than those younger than 50. Additional risk factors are lower socioeconomic status, less than a high school education, lack of transportation, pain associated with screening procedures, lack of insurance, lack of primary care provider, immigrant status, and high out-of-pocket costs. One study found that 94% of people who had not been screened reported that their doctor never discussed the screening with them.
Whoa. So let's move on to perceived benefits now.
Well, screening can detect and facilitate the removal of precancerous polyps. Colonoscopies have a high predictive value for colorectal cancer and can detect cancer at its earliest stages. External cues to action include the many organizations that have devoted themselves to increasing screening adherence. The Colon Cancer Alliance has sponsored various grants and programs to raise money and awareness for colon cancer, such as their family-friendly Undie Run.
Oh, wow.
There are also internal cues to action. People are more likely to get screened if they perceive the risk of colorectal cancer, believe that screening reduces colorectal cancer, think that it is important to follow screening guidelines, and tend to follow their doctor's recommendations. Finally, self-efficacy has been shown to predict the likelihood of colorectal screening and is a significant and independent predictor of colonoscopy attendance.
Wow, Amy. Sounds like you've really done your research. I think it's also really important to think about what we can do as CNLs. There are many ways to increase individual adherence rates by empowering individuals, increasing health literacy, self-efficacy, and perceived benefits, while decreasing perceived risks and barriers. In one study that significantly increased screening, the patient received standard care, was given a pamphlet with screening information, 2 personalized message pages that address personal barriers, and a reminder phone call. Another evidence-based model is a patient navigator model. In this study, the navigator met with the patient after the referral, explored patient barriers like cost in underserved populations, and reported problems at staff meetings to generate possible solutions. This program increased screening rates and endoscopy procedures. There are also strategies that influence healthcare systems that increase screenings. Primary care leadership and practice incentives are significant. Ideally, patient registries and reminder systems with prevention checklists increase outreach and cues of action. Policies that empower non-physician staff like nurses, just like us, to participate in screening activities has shown to increase rates. The development of systematic strategies that address language preferences and follow-up navigation decreases disparities and perceived barriers. In addition, community health centers that provide prevention classes has also been shown to increase screening and reduce barriers. How about we go call Ms. Polyps right now?
You know, I was thinking, there are a lot of social and health policy implications for screening. The cost effectiveness is up to $93,000 per life year. However, thank goodness that under the Affordable Care Act, screening colonoscopies are now fully covered.
So you don't have to pay for anything?
No, there are still out-of-pocket costs in Medicare. Patients pay a 20% coinsurance, and if they find a polyp, it is considered a diagnostic colonoscopy in which patients have to pay out-of-pocket. Apparently, though, by 2014, all private healthcare plans will be required to cover all colorectal cancer screening tests, and the deductible will be waived even when polyps are detected and removed. The Affordable Care Act also creates a public health investment fund to expand and sustain screenings. Hopefully, this will all really enhance population-based screenings. Wow, I've been thinking about all of our friends that haven't been screened. I wonder what we can do.
Well, I do have one idea for a health policy intervention, and that's to increase the population-based screening. The insurance companies need to start fairly compensating offices for prevention measures and incentivize doctors to promote the colorectal cancer screening.
True.
We need to lobby our California senators, Barbara Boxer and Dianne Feinstein, and gather allies such as the American Cancer Society and Colon Cancer Alliance. Also, when considering health disparities, faith-based programs can improve outcomes in minority populations. We should work with our church director to bring awareness to the community by having an informational booth this Sunday. Some people tend to trust their familiar church more so than their healthcare providers, whom they rarely see.
Well, I'm going to write a letter to the American Gastroenterology Association about the importance of increasing the number of women that are gastroenterologists. Currently, less than 5% of women are members of this association. It was so important to me to have a female doctor. I can't even tell you.
That's it? Wow. All right, let's go get started.
Okay.
Wouldn't it be nice?